today to have Director of CMS, Malcom Weems. He came from Chicago down to talk to us about the health insurance for state employees or retirees, Senate Bill 1313. And while this doesn't affect community colleges, we thought it's very important for all of you to hear the message. Along with him is Janice Bonneville, and I just have to give this little bit of, what do I want to say, compliment to the both of them for allowing SUAA and two other groups from SERS to participate in talking to them about the, I've been calling them nooks and crannies of how the healthcare system has been built, especially throughout SERS system. So without further ado, Director Weems.
Sorry about that, I'm a little tall. Thank you all. Thank you SUAA, thank you Linda. Really thank you all for taking the time to even hear what we have to say. A lot of times in state government, it's usually folks are upset, and it's because of confusion. And I think we agree, just with, like most folks, that with the Senate Bill 1313 passing, that there are a lot of questions that still need to be answered. And we know that it has caused really some frustration with retirees. So our goal really today is, I want to do a couple of things. First, I want to let you all know about CMS's commitment to working with groups like this to make sure that people understand the process, understand that this is not a process that CMS is going into lightly, and nor are we going into it not expecting to work with other organizations to make sure that we can at least, where we arrive is somewhere that we got there thoughtfully, we got as much input as possible, but the most important part for us is making sure that we're following the law and that we're compliant with the law. So a lot of what we're doing in terms of reaching out and having discussions and sharing information, making sure we don't leave any stone unturned, in the back of our mind we always have to, we're moving forward. You know, this is about deciding if something is going to be done. Senate Bill 1313 is, I don't believe is signed by the governor yet, but it's moving to be signed, and we know that we have to be compliant with the law and we have to get started on implementation. There are a lot of things that have to happen so that we can get more information to the public. So there are things that have to happen. We have a bargaining unit agreement going on at the same time. We'll have to present our rules to JCAR, the Joint Commission on, it's the body that actually comes up with that approves the rules. And we really just want to make sure that we're moving as fast as possible, but at the same time involving organizations that are looking out for the population that will be affected. So again, I'm here really just to make sure that we can answer as many questions as possible, to make sure that you understand the governor's commitment and our agency's commitment to trying to do this in the best way possible, and that we're listening. There are a lot of nuances that are involved in this new legislation. We want to make sure we address them all, and we want to make sure that we hear all of your thoughts about those nuances. I'm here with my Deputy Director, Janice Bonneville, who is more of our technical expert. She's outstanding. She does a really good job. She's working on benefits for the state for now, I want to say over 6 years. And again, I rely on her heavily. But again, this is the stuff she knows, and I'm very confident that Janice is going to lead us in the right direction. And again, working with Linda has been great. We work with others as well. And again, I hope today we can answer some of your questions. Some of them we won't have the answers for yet, but we'll come back. The idea, this isn't a one-time meeting. You can expect to see us again as more information comes forth and more developments are made. Okay? Janice?
My name is Janice Bonneville. I'm the Deputy Director of Benefits. I've been the Deputy Director of Benefits for 6.5 years. I started with the state 7 years ago this July as the lawyer for the Bureau of Benefits, and 4 months later the then director said, hey, how would you like to be the Deputy Director of Benefits? Because there isn't one anymore. Just for a little while, So here I am 6.5 years later. So Senate Bill 1313 says the director of CMS shall set the rates for retiree health care. The director of CMS shall set the rates for retiree health care. It takes out everything else that's already in that act that talks about 5% rules and talks about years of service and says the director shall set the rates. Pretty vague, okay? There was discussion on the floor, and my job is to kind of tell you where we are and what our vision is. Okay, as Linda indicated, we are talking to retiree groups. We are talking to, I'm getting a cheer from the back of the room from one of them. We are also talking to the union because the retiree health care that's in the act now is in the bargaining contract. So we've got a couple steps to go through before we actually move this into place. Okay, so the concept behind retiree health care premiums relies upon a couple of things. First of all, it looks at your age at the time that you retired. Okay, it adds that to your years of service to give you a point value. We then take that point value and put it on a grid against the value of your annuity. Not your income, your annuity. That annuity, for any of you who have annuities for more than one system, includes any annuities you receive from any one of the 5 state systems. Okay, so that equals your total annuity from the state of Illinois. That includes member and survivor annuity. So if you have an annuity from another system as a survivor or another system as a member, those numbers are all going to get combined to determine your full annuity. Okay? This is a hard concept to see, but let me explain it to you. It's an XY axis, and don't shoot me if I forget which one's which. But across the top are my points. So I have 0 to, and I'll actually give you what the points are right now, 0 to 59, 60 to 69, 70 to 79, 80 to 89, and 90 and above. Those are your points, age plus years of service. On the down axis are the values of your annuities. Right now, I'm not sure I can rattle those off. Right now we have 9 of them. I think I probably can. They're less than 11,000, 11 to 22, or 21,999, or whichever way we go with that, 22 to 33, 33 to 44, 44 to 66, 66 to 88, 88 to 110. Oh, believe me, there's people, I'm still getting there. My last group is greater than $143,000. And there are members and survivors in that bracket. Folks that are receiving annuities that are greater than $143,000. So depending on where you fall on the grid, the higher your years of service, your combined points, and the lower your annuity, the less you're paying. So if everyone in the room, for example, was in the highest category, which, by the way, if you're a current retiree under SURS in the state plan, you are in the highest category because that's the way the agreement is written. You already all default to 90 plus or whatever we decide that highest tier is. Okay? So if I'm in the 90 plus tier, I'll use myself and my director as an example, and I make my annuity as a deputy director of $22,000, and he makes his annuity as a director of $143,000. I'm going to pay a lower percentage than he is. We have the same number of years of service, same age at retirement, the same number of total points. But because my annuity is lower, my cost is lower. The cost is a percentage base, and it's based upon the cost of coverage. Okay, so what does that mean? Being the spry, young retiree that I am, sorry boss, as opposed to the older retiree that my boss is, I'm going to be paying a non-Medicare rate. So my rate's going to be a little bit higher bear with me, don't give up on me yet on this non-Medicare thing. I know what you're going to ask me. My rate's going to be a little bit higher because the non-Medicare rate is higher. Once you get to Medicare, the state costs drop, the overall cost of the plan drops, so your percentage is based upon a lower base number. So if my rate's 300 and my percentage is 10%, his rate may be 150, even though his percentage is 30%, his payment might actually be lower than mine. I didn't do that math in my head, so forgive me if I made a mistake. Okay? Makes sense conceptually? Okay. Here's what you need to know. First of all, we're not there yet. Okay? We are not there yet. Senate Bill 1313 is effective July 1. That does not mean you're going to start paying for health care on July 1. It has to be negotiated with the union and it has to be presented before JCAR. If we reach an agreement with the union, we get a JCAR, or excuse me, I get in front of JCAR and they say no, we've got to go back and start again. I've got to get them through rules and negotiations before we can implement them to you. Okay, so when you call my office and my staff say, I'm sorry, I just don't know what your rate's going to be yet, they truly just don't know what your rate's going to be yet. Okay, because it hasn't been decided. It hasn't been determined. But the concept has been decided. Okay, let me address the Medicare piece and just kind of get it off the table. I would anticipate there are a few folks in the room here that are not Medicare eligible and will never be Medicare eligible because it wasn't an option for you as a retiree. Guess what? For purposes of health care, you're calculated on the rate as if you were Medicare eligible. That's not reflected right now on your benefit statements that you get from me because that's an adjustment for us. But because your lack of Medicare eligibility, not people who decide I'm not going to pay in for Medicare, okay? People who are in a position for which they will never, ever be Medicare eligible. Those folks will be treated as if they are Medicare eligible. Okay? Which means your base cost will be lower. The premium we look at, cost of coverage, is going to be lower than if you are non-Medicare eligible. Okay? It's not an easy concept. Okay, I see grids in my head because I've seen them so many times. But please don't be frustrated if you walk away today and say, I still don't really quite kind of know what happened. Please understand that you have time. It's our responsibility to explain it to you. But I can't explain it to you until we get everything laid out. What has happened is, we talk about Senate Bill 1313. That's the bill that passed, very generic. There's other bills out there that allegedly have the tiers in them. There aren't tiers out there. They haven't been established yet. We know conceptually what we're looking at. But if you've ever been in union negotiations, sometimes the concept on the management side of the table isn't exactly what happens at the end of the day. I don't know why, but sometimes it doesn't. So we're a long way from getting the final numbers. Okay, what does that mean for you as a retiree in the state? And remember, I don't know how many SIP folks we have in the room. This is state plan. Okay, SIP, you guys pay differently. You're already paying a higher percentage of your own cost and you're already paying your dependent costs. So this piece is not about you. You can take a nap, you can do whatever you want to do. But this is not SIP. Okay, this is state plan only. What that means for you right now is, well, first of all, benefit choice is over. So if you didn't make a change, don't make one now. But I wouldn't make a change. If someone would have called me the middle of April and said, or the middle of May and said, what should I do? I've told every group I've spoken to, unless you're unhappy with your carrier, or you've got a change that you've got to make because you're adding a dependent or dropping a dependent or you've moved or something like that, just stay where you are. Okay? Once we get everything in place, I've got 3 planets that have to align. 3 planets. One, this is a concept that won't be unfamiliar to all of you. We've got to have managed care vendors. Okay? We've got vendors on board right now that are on 90-day contracts for the 2nd year. Okay? We're finishing up that RFP. I can tell you that both of those vendors bid on that RFP, which might be good news for some of you. I don't know how that's all going to play out, but we're working through it. So we've got, first of all, to deal with the vendor question. Are the vendors still going to all be available in the spaces they're currently available? Secondly, we've got to deal with state plan design. State plan design, co-pays, co-insurance, deductibles, those are all part of the union contract. No plan design changes happened this year because the union contract finalized. Third piece, retiree health care. Part of the union contract and the administrative rule piece. So in a perfect world, all my planets will align, and sometime this fall, I'll have a special enrollment period where you address all of those issues at one time. If the planets don't align perfectly, I've got to have more than one special enrollment period, and that's not what I want to do. I want to have one so you can make those decisions at that time. Okay? It's a lot of work for us to hold a special enrollment period, but I just can't simply say, I'm sorry, I'm charging you for health care. Okay, when we started charging, I'll say this and hopefully nobody will throw anything at me. A few years back when I said, I'm sorry, I'm charging you for dental, we said you have until this date to opt in or opt out. You had a window of opportunity before we started charging you. The anticipation is this will be the same situation. You will have a window of opportunity in order to decide what you're going to do. I will honestly tell you that depending on the timing, there could be a window where I'm saying charging starts today and open enrollment is this day. But ideally, I would say open enrollment is this day and charging is this day. That is a function of the entire process to include me getting in front of JCAR. Okay, so again, this is my perfect world. It's my own dreamland that I live in. Okay, but that is the way everything has to line up for retiree health care. Now, with all of that said, because I know we don't have a lot of time, do you have questions? Oh, I know you do. Okay, this is how I do this, and I'm sorry guys, I'm going to start on this side of the room. So I always just work across the room and then I'll come back across. So yes ma'am. She was writing questions down before we even started speaking. Yes ma'am.
Yes, when you talk about bargaining, first of all I want to know if negotiations are going on right now, and is AFSCME bargaining for all state employees?
The reason bargaining matters is because in 1998, 5%, what I call the 5% rule, 5% a year for every year of state service up to 20 years. The 5% rule is in the bargaining contract. Okay, it was put in the bargaining contract before it was put into legislation with the agreement that it would only go into place if it went into legislation. That's point one. Point two is the Public Labor Relations Act says if there's a conflict between the law and the collective bargaining agreement, the collective bargaining agreement controls. For purposes of group insurance, except for Section 5, yada, yada, yada. So right now I have a conflict between the law and the collective bargaining agreement. So we're at the table figuring it out. The law can be vague with respect to what our role is. We can set it by rule. It can just say the director shall set the rates. And then we work out the details in the background. Point number three is there's a section of the Group Insurance Act that says anything that I give to a non-bargaining employee, I must give to a bargaining employee. And anything I give to a bargaining employee, I can choose to give or not give to a non-bargaining employee. Okay? So I'm trying not to have two different programs. I'd really like to have a single program that everybody who's on the state plan gets this benefit and this design and these premiums, as opposed to this group gets this and this group gets this and this group gets this. If any of you are familiar with what we do, we bargain with AFSCME under the governor because they're the recognized unit, but by no means are they the only unit. We bargain with the Teamsters, we bargain with the INA, we bargain with SEIU, we bargain with a number of unions. AFSCME just happens to be the only one we bargain with regard to health care. Okay? Does that answer your question, ma'am? Okay. Hang on, ma'am. You weren't... yes, sir.
I think you misstated the people who are not eligible for Medicare. Would you restate what you said earlier?
You think I misstated the people who are not eligible for Medicare?
Yes.
Can you tell me why you think that and I can clarify?
I think you made a statement where you meant to say Medicare eligible versus non-Medicare eligible, And if you could just explain the process again, that would be helpful. For the position of CMS.
For the position of CMS.
People who are non-Medicare eligible never were, never will be.
For those people who are non-Medicare eligible, never were, never will be. Now there's a difference here. There are positions right now where people have a higher retirement annuity at SURS, but there are certain people who, prior to the time that Medicare was Medicare, that never had the option to decide if they wanted to be Medicare or non-Medicare. Okay, never had that option. There are, I can tell you, there are approximately 4,400 people in this group. Those folks have already been identified, and their premiums will be coded in my membership system as if they were Medicare. So they'll pay the lower rate. Yes, Linda, have I misspoken?
No, you have not, but I think the clarification needs to be that those who are non-eligible for Medicare, who never will be, we're talking about age 65.
Oh, yes, I'm sorry, age 65 and over.
Oh, yeah, 65.
Right, because everybody would have to, yeah, because you can't get the Medicare benefit. I apologize. Thank you, Linda, for that. Does that clarify, sir? Okay. No? Yes, sir. Yes, sir, you.
Is it going to be retroactive? You said July 1.
Is it going to be retroactive July 1? You're smiling at me. I'm going to give the answer I've been given. In my mind, no, it's not. It's not going to be retroactive. I don't have a mechanism to go back and collect premiums to you retroactively. Okay? Yes, sir. Oh, there's a follow-up.
In your concept of this 9x5 matrix, do the numbers, the percentages range from 0 to 100?
In the concept of the matrix, do they range 0 to 100? No. They don't.
Is 0 the minimum?
No.
So we're not going to have what we had with 20 years of service?
Currently, the question is 0 the minimum? Currently, I don't have a 0 in my head. Okay? Again, we're at a bargaining table. I don't know, I could have zeros on my whole grid by the time this is over. But right now, conceptually, no, there's not a 0 on my grid. I wish I could tell you there's not 100, but that would be a falsehood, sir. But yeah, there are no zeros on my grid. Yes, sir, in the very back, and then to you, ma'am.
Presently, do retirees pay 100% of the premium for their spouses?
Currently, do retirees pay 100% of the premium for their spouses? Under SIP, yes. Under state, no.
Oh, we don't?
No, sir, not even close.
So what's going to happen?
There will be a grid for a member and a grid for your dependent. And the cost within those grids will be percentage of cost based upon your age plus years, your annuity, and the plan that you choose. Okay? Yes, ma'am.
I wondered about the RFP. It sounded as if CMS did the RFP this year for managed care. Is that correct?
Okay, the question is about the RFP for managed care. Did CMS do it? No, but in 2 weeks it belongs to me. I don't. This is kind of a nuance that some people know and some people don't. About before I arrived in the state, there was an executive order that took that purchasing piece out of CMS and moved it to HFS, formerly Public Aid, now Healthcare and Family Services, to combine all healthcare purchasing. Since Director Weems has come on board, we've had multiple discussions with the governor's office, and this year, Executive Order 12-01 was that said, no, put it back. So those folks come back to me, come back to my bureau 2 weeks from yesterday. And most of them are very happy, except for the 1 or 2 that have to hang out to get a few things wrapped up at HFS. But I will tell you that CMS has been intimately involved. I don't think this is going to go badly for me, but we've been intimately involved in this procurement to try to overcome some of the things that we saw in the past and some of the situations we were put in where I'm trying to come out and speak to you, or my staff are trying to speak to you on the phone, and we frankly don't have answers for you, or something goes wrong. I'll tell you anecdotally, just for 1 second. Were any of you in the SURS meetings that were held in Champaign-Urbana last year. They were on a Friday. We had one in the morning and one in the afternoon just to talk about what your options were. I did those meetings. I spoke for almost 4 hours to the morning session and then started the afternoon session like 15 minutes later and spoke all day. That was the day that Judge Otwell entered his stay against what we were trying to do with it, so everything I said that entire day was a lie. I mean, I told all these people this is what you should do, these are your choices, and then the stay was entered and it was over. So I'm trying not to have that happen this year. I really don't care for that position for myself. So, and I have a few folks in here that are in these side meetings with me, so they can let you know right away if I'm giving you anything that is an untruth. I'm certain that they will check me on it. Okay, was there anybody else over here? Ma'am.
I want to know about the payments when they're going in. Are those actually going to be earmarked to pay our bills? Because many of us have CMS bills that are way, way behind, and we're paying up front for our current health care.
So the question is, will the money that you're paying in now be earmarked to pay the bills? Ideally, yes. However, if you have paid attention to the budget for next fiscal year, we requested $1.1 billion in the governor's budget for group health. That was a reduction of $321 million. $200 million of that was retiree health care, and $121 was other savings under the active side. The General Assembly gave us $550 million. So the chances of this paying off all your bills, not right now. We have some other items we're talking about. The director and I just had a discussion this morning about what our options may be. But right now, no, this money will not be sufficient to catch up the bills that we currently have on board. We have about $1.1 billion in bills in hold.
Well, let's not scare anyone. The intent is once we have the rates set, the legislature wants to come back in either at during veto session. I'm sorry, I have to, either during veto session or in January to actually talk about funding the other half. But currently, Janice is correct, the funding is not there.
He can tell you what the General Assembly's intent is, I can't. So, yes ma'am, and then I'm moving to that side.
Your total annuity would be considered any annuities from the 5,
Correct. Any annuities from one of the 5 state systems.
What about if you have an annuity with the city? Part of your annuity is the city, nothing?
No. If you have a city annuity, if you have an IMRF annuity, no. 5 state system, because frankly folks, that's the information I can capture, and that's the annuity being paid by the state. I was given an example from teachers. They have a member who has a member and a survivor annuity from TRS, a member and a survivor annuity from SERS, and a member and a survivor annuity from IMRF. I'm going to count 4 of those when I determine what that person's annuity is from the state of Illinois. Okay? Over on this side. Yes, sir. You've been so patient.
And, I think Senate Bill 1673 or whatever, they talk about choose the COLA or if you do, you lose access to health care. What does the word access to health care mean?
Okay, I was trying to avoid this bill, but I'll address that question. The question is Senate Bill 1673, which is the other pension, is the pension bill that also affects health care. My understanding of the intent of 1673 is that if you choose the COLA, the compounding COLA as you currently have it, you will be deemed ineligible to enroll in the group health insurance program.
And you can't purchase it?
You cannot purchase it. There is no, it is not about no state subsidy. It is you are deemed an ineligible member.
And where does affordable health care, where do you think affordable health care is going to fit in all of this?
Where do I think affordable health care is going to, sir, I'm not really sure. Again, as I think the director made in the original comments, we are implementing the law as it was written. We didn't write it, we're implementing as it was written. Okay? Yes, sir.
So I hope this isn't impolite, but the purpose of SB 1313 is to lower the cost of the state. I think you just said the retiree is $300 million. So is your goal to reduce that by 100 million, 200 million?
The goal on retiree health care, as testified by the director of GOMB, is $200 million. That's the target, to reduce the cost of the state for health care long-term. It also reduces the state's long-term liability for its pension systems by having a pay-in for retiree health care. I'm not sure that, I know that answers your question. I'm sure it doesn't satisfy your question, but I know it answers your question. Okay? Yes, sir?
If a retiree has a spouse that works for a university, can the retiree become a dependent of the spouse?
If the retiree has a spouse that works for the university, can the retiree become a dependent of the spouse? No.
Is that, I guess why is that? Because a retiree can work for another company and become a dependent of that person.
The way the question is why not if they work for someone else they can be a dependent? Because the way the Group Insurance Act is written is every one of you are a member in your own right. The only exception to that is for folks who leave state service. There's something out there called an annuitant waiver. Folks who leave state service before they actually become a retiree and haven't started receiving their annuity yet, we call them deferred annuitants. You're receiving your annuity a year or later after you leave state service. The Act has a clause that was written in some years ago that allows that person to either be a member or be a dependent. I will tell you, well, it wouldn't necessarily be true for an active employee, but I will tell you frankly that in the numbers in my mind, it will be more cost effective to be a member in your own right than it will be to be a dependent if your spouse is also an annuitant. As an active, that would not hold true, but the only way you can drop my health care under the Group Insurance Act is if you can show me you have coverage from a source other than the Department of Central Management Services. And that would not be the case. Okay? Yes, ma'am.
Under the state plan, or what you see, do you think that the benefits that we now have will be pretty much the same, like will there be dental, prescription, or are you looking at something kind of different?
Under the state plan, do I think they're going to keep the benefits we currently have? I don't anticipate changes to the types of benefits that we have, okay? The group health plan has the pharmacy, medical, behavioral health, and vision. That's a bundle under the Act. And then the dental is an add-on. I don't anticipate either one of those pieces going away.
Would the dental still be an add-on as it is now, or something?
The dental will remain an add-on as it is now, with its own separate premium. It's not included in this calculation. Your dental premium is going to be something similar to what you're paying right now. I can't say it's going to not change because that's a bargaining issue, but it is going to be something similar to what you're paying right now. Okay? Yes, sir?
This is a follow-up to the question you previously asked, and you might not have the answer, but I have a feeling your answer is not going to be good. What happens if that core option comes in and people decide they want to take the COLA, and you're 80 or 90 years old?
If you decide to take the COLA and you're 80 or 90 years old, where do you go? I don't think I have the answer to that, sir. There have been some discussions in the Dome about health insurance exchanges and various items like that, but there's nothing really designed out there yet for that issue. And let me just remind everybody, we're not there yet. Okay, pension reform hasn't passed yet. This retiree health care piece, this percentage of cost, is going to be in place potentially before pension reform passes, certainly before pension reform comes to fruition. Okay, before we actually get to the spot where we're making those decisions and making those changes. Okay, yes, sir? If federal health care stays in effect, how does that affect what CMS is doing? It doesn't. The mandates on the employer are to provide health care. The only piece about federal health care that really impacted retirees was the ability to get money back if you covered early retirees. Okay, we didn't do that. We have a little thing, yeah, you can only get money back if the claim's been paid. So we ran into a little loophole there that we couldn't really claim claims because we've got a little bit of a claims hold. So it doesn't impact what we're doing here. And the reality of it is many of the things that we've implemented under federal health care, some of those things are already in place under state law, so they weren't big changes for us. But right now it doesn't I don't anticipate it'll have any effect on what's happening here. Yes, ma'am. Let me work back forward. Okay. Yes, ma'am. The question is, if you're 65, under 65, when you reach 65, does your premium go down? Well, think about, well, it depends on The issue on Medicare eligibility is if by some form or fashion Medicare wasn't an option for you. Okay, so yes, if you get to 65, whether you're Medicare eligible or ineligible, if you're Medicare eligible, it goes down because you're in Medicare. If you're Medicare ineligible because you can never be eligible for Medicare, yes, your premium would go down. Okay? Okay. Yes, ma'am. Sorry. I think the COLA will be compounded. I'm not invited to the meetings on pension reform. Frankly, I wasn't invited to the meetings on retiree health care until the bill passed, and then they said, hey, by the way, we've got this bill for you to implement. So I don't know the answers to those questions. I know conceptually what they're looking at, and I know the answer to the question about what does it mean for access, but I don't really know where pension reform is going to go. Sorry. Yes, ma'am?
When you're calculating years of service, do we include...
Calculating years of service, do we include sick leave that you've added on? Yes. Anytime that you bought back is going to be included in your years of service. And we're looking to the retirement systems. They're feeding us all that data. Okay, they're giving us all the information about what your years of service are and what your annuity is.